All right, here we go.
Right.
All right, Andrew, we will wait a little bit more minutes before we actually start the conversation, but I already want to dive in and don't have like 3 or 5 minutes of awkward silence. So maybe a question to you to kick things off for the audience. What is the book that you have recommended most to other people, and why is that?
So I recommend a lot of books. I've actually been made fun of that when you ask me for help, you get a book. And I get that from my dad, who always had a book for me to read next. And I try and do the same with my children. I think the book I recommend the most, and I'm looking because all of my books are right here. That's why I look up a lot while I'm doing these talks because one of my old bosses, Bobby Sabuka, used to ask me, like, what's on your ceiling? Because you always look up there when you don't know what to say. I'm like, wait, it's all the books. So uh, probably The Goal. I recommend that a lot. It's really simplified life for me. And I read The Goal when I was in my early 30s and I have one or two children. And the reason I have three now, and the reason why that's important is about half the book is the main character fighting with his spouse about never being home because he's working all the time because he's doing such a bad job. And when I talk to folks who read it in business school when they're like 20s before they had a family, they totally missed that part of it. They're like, oh yeah, it's about the factory and the drum and the herbies and the high. I'm like, yeah, but there's a whole part about how your life falls apart when you don't do this right, which didn't have a life yet at 26 that could fall apart. And so that's why I love that book. And I try and get people to reread it because it's even more impactful as you get like further in the milestones in life.
It's funny that you mentioned that because I finished the Phoenix project and there is also like a lot of information about him being late all the time, and I actually also never thought about that lens. So it's a good lens. You
It's
actually
very,
also
very real.
in your blog you also recommended the tools which I bought
Yes.
just now, so I will diving into that in the next couple of days as well. And then maybe a second question before we actually kick things off. You also wrote in 2016, and yes, I've been very deep into your blog, which is a very good one, by the way. You mentioned patterns keep repeating through medicine, software development, management, parenting. So maybe a question to you now is like, what is a pattern that you recently noticed between healthcare and any of those categories?
Um, yeah, first I want to confess that I'm a lumper. So I think everything's the same as everything else. Um, the pattern that I'm seeing in healthcare now, unfortunately, is it feels like we're on the gasp of a hype cycle. And so I feel like hype cycles go through everything. There are, parenting hype cycles, there's new fads and trends of what to do, there's fashion, etc. And so sadly, what I'm seeing is there's a lot of technology hype and kind of oversimplification business model hype is maybe the other way to think about it, that we're seeing the end of right now. And that's a pattern that I'm not happy about, but I can't deny its existence.
It's a good lens to keep in mind, and also to your point in the blog that black swans can change a hype cycle completely
Yes.
pretty fast.
Yes. Like there's something in all the technology we're working with. There's something in all these businesses. It's just not what we think. My actual mental model for health, like health improvement, digital health, health tech, whatever you want to call it, service innovation, is the movie World War Z, which is not a great movie, but is a great book. And there's a scene it takes place in Israel where they built a wall around Jerusalem. And the way the zombies get in and over the wall is one of them slams into the wall and falls down. And the next one slams and falls down. And you eventually get this massive, like 2, 3 story pile of zombie bodies, and zombies start running over the pile. So every one of our companies is either in the pile or going over, and we don't know until we get there. But that's my mental model for innovation. Like we'll just keep slamming our head against the wall, and eventually we'll figure something out.
I love that. And many people in the health tech graveyard will definitely love with that. So
Yes, yes, we stand on the shoulders of giants and zombies.
all right, let's kick in. Before I ask you some very serious questions, can you maybe briefly introduce yourself to the audience to set the stage and why you're here today?
Sure. Thank you, Rick. So Andrew Schutzbank. I'm a primary care physician trained in internal medicine. I live in Cambridge, Massachusetts. I have 3 children, aged 12, 8, and 4. You may hear one in the other room. He was sick last night, so he may make an appearance at some point in the next hour. So basically, trained internal medicine here in Boston. That's what brought me to town. Before that, I was in med school in New Orleans during Hurricane Katrina at Tulane, and was involved with actually moving the school from New Orleans to the Texas Medical Center. Came up here for residency, met a gentleman named Rashika Fernando Pule, who was a rock star and a mentor and a wonderful human being. And he said he wanted to start a company to change primary care, and so did I. And so I latched on and never let go. I spent about 10 years at Iora Health, and that's what we'll talk about most of today. From there, I went on to Cricket Health. Both of those companies exited 21, 22, did a year at Scan as an operating partner running a series of startups. And I've actually been a full-time, part-time advisor to a bunch of healthcare startups for about the last 15 months or so through an organization called Schutzbank. And I write at the Schutz blog, which is the blog you mentioned earlier, which is probably the consistently hardest thing that I do, but the thing I enjoy the most professionally. It's just getting the words out every week, every 2 weeks. So pleasure to be here today. Thank you.
And you do an excellent job of writing that down. So I would definitely recommend everyone here reading it. So to introduce myself briefly, so I'm Rick. I'm also a clinician. I'm a nurse. Also have my master's management and policy in healthcare. Always thought that I would become an oncology nurse, but then I met the CEO and co-founder of AWell, and he convinced me to join the startup world. So now I lead clinical strategy. So with AWell, what we do is we implement clinical workflows at health systems and tech-enabled care organizations, and I make sure that what gets implemented is also driving better outcomes for patients, but also for caregivers. Now, we're not here to talk about me. We're here to talk about Iora Health and all the stuff that you did there. Maybe a first question that I have. So Iora Health started in 2011. And you had like health coaches that went to the supermarket with patients, they watched television, they even read books. And so now 2024, we're all focused on profitability. And I think, or I believe that not everything from the Iora Health model can be replicated in 2024. And so question to you, like if you were to start Iora Health again today, which part of the care model would you keep and which parts would you change?
Sure. Think about this question a lot. We had a long time and did many iterations of the model. Just in brief, Iora was 3 kind of nested businesses with one another. The first era was self-insured employers and unions for the most part. The reason why that was important, it was I will never hesitate to share the Schutz blog link. Here we go. Okay. Thank you, Bethlehem. So the first set of businesses was for employers and self-insured employers and unions. People had something in common through their employment, but they had a pretty long-standing employment. That model was basically a PMPM primary care cap with upside and downside based on performance more than risk. And it actually freed us from a bunch of billing and coding and what I'll call nonsensical documentation requirements, where the original Iora model was born. And I think that was the purest iteration of it. And I'd love to see us get back to that. I can get back to that later, why that's so important. The second iteration was called Harken Health, which was a joint program with United. And that was built for the Affordable Care Act exchanges. Folks originally, birth to 65 and then eventually 18-ish to 65. The challenges there were mostly political and outside of our control in some ways. United pulled out the exchanges, but the real story is when there's a new insurance product, don't rush to build a care model for it, because it takes a couple of years to figure out how the insurance actually works. Because the biggest challenge with insurance is they get 1-year cycles. So if we want to talk fast iteration agile development, they get 1 year, like one shot a year fundamentally. So it ends up being a very slow to change business because they don't get a lot of smaller iterations. They do things to try and get smaller iterations and simulate fast iterations, but fundamentally they get 1 shot a year. So hard business to be in. And then the third business where Iora kind of spent the longest and got the most revenue and valuation from is from our Medicare Advantage business and original Medicare. And that was really Iora tailored to seniors. So common elements amongst all of those, multidisciplinary care team centered around a primary relationship with a primary care provider, which was either MD or supervised NP. Heavier on MDs, but we definitely had NPs on the team. And then a health coach which was one person assigned to you as a patient who's kind of your relational task finesse master, right? And what you realize with the health coach, a lot of what they were doing is able to labor arbitrage off docs. So docs could do, the best docs waste their time. And I don't mean like they spend more time with patients. I mean like we would pull up Google Maps to help you get car directions from where you were to your pharmacy. So like that's very helpful, but doctor time's really finite. And so for us to do that's a waste of time. So you need another person to come in to the work is valuable. And that's where the health coach idea came from. It started with the Promotora model with the Latino Health Access Network. It was used across the country and across the world with community health workers. It was really honed in Atlantic City in the special care center, which is the precursor to Iora, where I got to see patients in for 2 days as a medical student or as a resident, and then kind of fully realized. So over time, the coach model got very bumpy in the sense that we actually changed the profile of our coaches, probably unintentionally. The early rule is that coaches need to live, should come from the communities we serve. So if we serve Casino Workers Union, they were either members of the union or their families. Same languages, same cultural understanding, same economic situation, same immigration patterns. As we got into seniors, we kind of let that go. We didn't have a lot of senior health coaches. We had some, but it wasn't intentional. And so you started to get a drift for the ability for our coaches to connect with our patients. And so they, as a result of that, you start to see more and more focus on like the tasks, job descriptions, what do they do, what are they supposed to be doing, become much more task oriented, and much less tasks were there to keep promises to serve the relationship, to keep care moving. So it's a long way of saying I'd keep health coaches, we kind of let go some of our discipline a little bit over time, maybe without realizing it. But the idea that you have another non-physician layperson from whom you get cultural competence and a lot of efficiency from is a very important part of care. And then the rest of the care team, nurse, behavioral health, incredibly important, but I think I would have done more, especially in a more virtual era, to keep those people more full, right? So because of the physical nature of our practices, you ended up with a lot of people whose panels couldn't be full if the docs panel wasn't full. So we had some ratio problems and other things. We also built our own technology, which was core to the model, which I would definitely do again. It was originally called the Iora Clinical Intelligence System, or ISIS. That in 2014, we renamed it CHIRP for obvious political reasons. And so there we lived. The second choice name was Canopy, and that actually became the name of our intranet wiki. So we kept both those names. Very tree-themed and bird-themed company. And so that was also crucial. We kind of get more into technology as we go. But everything else, like we created a lot of rules and happenstance for ourselves that maybe weren't so sacred, I'd let go of. But the fundamental idea of you need doctors, you need non-doctor relational specialists, and you need your own technology, that I think I'd keep pretty much anywhere in any kind of risk-based or value-based arrangement.
A lot of strings to pull from based on that. Maybe the first thing that I want to dive a little bit deeper on. So you mentioned that you have like these 3 business units. But then when I was reading the Harvard Business Review case study on Iora Health, the fact that you have different care models or different business models also means that you have different metrics that each model cares about.
Yeah.
So what was it then in terms of like North Star? Did you have different North Stars for each business unit or even for each state or each location, or how have you set the right targets for the organization to drive through?
So this was something we iterated on for the entire 10 years I was there. So our general sense, and again, I wasn't the only lumper in the company, our general sense was it would be better if we could have the same measures for all of our businesses. And that wasn't always possible or true. And then it became like, well, we could have the same type of measure, right? And so you wanted we want to grow at a rate that was appropriate for each kind of practice unit, each business line. We wanted to retain as many people as we could. We wanted to make sure that we were proactively taking care of patients, so doing all the things that needed to get done from a clinical guideline perspective, and then also having great outcomes as well, while kind of watching our operating cost. And so those measures iterated and changed a lot over time. Our data systems got a lot better. Our understanding of our business got better. But the other underlying complexity that's worth mentioning is even in different business lines, you had different patients, and different patients have very unique outcomes that change over time, right? So like the amount that I care about my blood pressure will change throughout my life, or my kidney function will change throughout my life, right? Or if my back really hurts today, I don't care so much about the other stuff. And when it's better, then I will. And so even with individual patients, you're kind of constantly cycling all of these ever-changing, individualized, idiosyncratic measures that you're then trying to roll up in some population level, both performance and measurement. And so it's hard, just fundamentally, to kind of keep track of all of that. But we kind of kept that same North Star of like, take great care of people, have a lot of fun doing it, make sure our costs didn't go out of control, and then take waste out of the system, and make sure that people kept coming back. We kept growing.
Yeah, I like that. Because oftentimes the North Star is something very tangible, but like have fun delivering care is also tangible, but it's not like drive this revenue or drive this number up, which is very smart if you have a very complex business model or multiple complex business models. And then so the other thing that I'm really interested in, and that's also again mentioned in the Harvard Business Review case, is Sherp, that came back like many times. And you also just mentioned, like, if I would start Iora Health today, again, I would again try to build part of the tech stack for me. So can you maybe explain to the audience the philosophy behind Chirp, and then why you would build it again today, and also like explain to the audience what it actually was or is today?
Sure. So Chirp was Iora's collaborative care, is Iora's collaborative care platform. It had EHR, electronic health record-like functions, because we're taking care of patients in a clinical way. It had CRM-like functions. When you get into primary care, you realize what you're really doing is tracking a lot of relationships with a lot of people. And like any good sales process, there's a next step and a next thing you're supposed to do, or they're supposed to do, and you're supposed to make sure it happens. And so we built, it's almost like an evidence-based CRM is a way to think about a lot of what we built. Furthermore, most electronic health records are still built around a fee-for-service chassis, which means it's one doctor, one patient, one encounter, one note, one bill. And that's kind of the core of the design, and everything is built around that. Ours was not. So ours was actually built around a team of people, so doc, coach, nurse, behavioral health specialist, taking care of a population of patients. So there's population measures as well as views into tasks and work that were much more central than the note writing and billing and coding, which honestly, we did some funky stuff with note writing early on because we didn't have to submit traditional SOAP notes in billable format. That's wasn't what we're required to do. We just had to document in a way that we could justify what we were doing, why we were doing, and kind of make sure we knew what to do next. And so we tried a lot of cool stuff with medical information, with note writing. From a EHR perspective, was much more of a problem-oriented record than an event-oriented record. And then the population health overlay meant that we had population data tied right back into the point of care. So you could quickly see who are your patients with each health coach, this from a doctor perspective, who has blood pressure, who has hypertension, whose blood pressure is in control and out of control, and then how to get it fixed. And as you went through your lists, you could click right through to the patient and get right to work. So the whole idea of Chirp was focused on the work to be done, not the notes to be written. There's a question about certified EHR. So yes, that came later as we started to get to more into government programs. And how did it work? That is a long answer that I'm not going to answer right now, but it took about a year for us to go from what we had to get certified EHR status by adding all the things around the edges that were required.
And some context as well. So I interviewed Oakshot Health a few months ago, and they also have they have Canopy, which is very similar to Sherp.
Yeah, fun name.
And then they have an EHR which they just use for the compliance reasons that Jake in the chat mentioned. But so one question that I also have is, obviously Iora spent millions on Sherp, and it's obviously a lot of money for a startup to invest in their own technology. Isn't the best way today to just buy like an API first EHR like MedPlume, Elation, Healthy, and then combine it with existing tools like Credo or AWell, which we also do? Or like, what's the reason that you would still advise to combine, buy, and build together?
Sure. So I agree. So a lot of those tools did not exist in 2014 when we got going. Sorry, 2011 when we got going. So 2014 is when we got into Medicare. So there's another round of kind of complexity. So yeah, and that's what I advise now. A lot of the Schutzworks clients, I do a lot of like one-off EHR selection gigs. There's also a lot of Iora engineers that have since moved on. I know a bunch are at Healthy now, which bodes well for them. So we always combined technologies. Chirp had underlying, our original CTO, Jamie McElhenney, was incredibly savvy at not building anything we didn't need to build if it wasn't differentiated. And so we spent as much time as we could on the clinical and patient interface parts of things and workflows. But the reason why it's worth all the money, there's no better manager for a remote distributed cognitive workforce than the software they use. I'm going to keep putting the Schutzbank link in there. Go for it. Because the software tells you what to do, right? Like we couldn't have had managers with all of our docs and there aren't enough people in the world to do that work. Thank you, Adriana. Good to see you. So couldn't have enough people to do that work. And so the software helps really get and codify what you believe out into the world. And so that's why I never give up control of that to some third party, the same way you'd never outsource all of your managers or all of your leadership to some third party. So I think that to me is sort of silly. I think people are willing to do that just don't understand technology or what it should be used for, and they think of it as something that's much harder or different than it is. Fundamentally, all of these EHRs are websites. Like we're not building brand new technology. It is the arrangement of the thing on the website that you work in, right? These are forms and fields. It is the complexity comes from the product side and service side. It doesn't come from, not to downplay the technology of it, but it really is how you want to run your company codified in software. And that's why I'd be loath to give it up.
Yeah, we have a concept at CareOps that essentially the product should inform the care flow, and that the product should reduce the cognitive load for the provider as much as possible, so they can just say, okay, for this patient, I need to do this, and for that, I need to do that. And they don't need to see the complex algorithms that are behind that logic. So that makes sense. And then to talk a little bit more on that second point. So in the business case, it was mentioned that you looked at off-the-shelf EHRs, but you wanted to have some modifications on like the metrics that they see as like threshold to trigger an alert. And you were like, no, we want to have different thresholds and we want to so have modification. And then they said to you, we can do that, but then it will take 9 to 12 months to deliver that. And so is that what you mean by you need some flexibility on that side, or can you unpack that a little bit more?
It's even deeper than that. So in the special care center, Rashika and Neil Patel worked with eClinicalWorks. And before that, Rashika had a practice. He worked with Greenway. And a good relationship with Greenway guys to get things fixed. If you know Rashika, he's very good at convincing you to work on what he wants to work on. He's a very compelling individual. But even that, it was not only was it not fast enough, but they're just what we were trying to do was fundamentally against the architecture of the technology at the time. Right. So if you think about what a encounter-based EHR is, and our entire claims, billing, auditing, and compliance system, it is the technological equivalent of putting a message in a bottle, throwing it in the ocean. Right. So when you print out a note or send a note, it has to have all the information that someone might want. So it has to be this complete standalone product. So you're basically ignoring all the other information in the EHR every time you send a note out. And so you end up with two options. You either send a note with a lot of junk in it because you don't know what people are going to need, so you just include everything. Or your notes are very sparse. People don't know what they need, and you end up in this endless queuing request process. So we actually don't use EHRs as EHRs. We don't use them as deep databases of clinical knowledge. We use them as generators of messages and bottles that we throw in the ocean and someone else picks up and reads, right? Which is really dumb when you think about it. And so that's why we built our own technologies. Mostly, Rashika tried twice before with other people's technology, and it didn't work. And so we were able to raise money. And at the time, it was always seen as a very challenging thing to do. At no point in our process at Iora and building Chirp, people were like, oh, yeah, of course you do that. That's so easy. Like every week I had to defend why we weren't outsourcing our technology or outsourcing our engineering. Pretty much the whole time I was in charge of technology. But it made such a crucial difference in the way that we operated. And a lot of the things we figured out about service came from the discipline of building technology. So Agile, DevOps, measurement, all these concepts came in. They came from our software team. We just applied them to our clinical service in ways that we wouldn't have because we wouldn't have been exposed to them.
I'm happy that you mentioned DevOps. So DevOps is obviously all about continuous improvement and moving fast, while healthcare we're used to move in months or years to get shit done. And so maybe can you like argument to the audience why speed and iteration is important, both from a tech stack perspective, but also from a care model perspective?
Sure. So we always move fast in healthcare. We just don't move differently. So like if you've ever worked, especially in any clinic I've ever worked, inpatient ward, you're always running, right? There's a joke like you got to put your roller skates on today because you're moving fast. So we always work incredibly quickly. We just don't work well because time's always of the essence. People are always waiting. It's a combination of your enemy is disease, so time is against you, but also the demand for your services exceeds the supply, so people are waiting. So there's always pressure to move on the clinical side of things. Again, on the insurance side, they're working in 1-year cycles. So that cadence has slowed all of us down by the nature of the insurance model. And it's not a complaint, it's an observation. So from a clinical perspective, the reason why you want to iterate fundamentally is twofold. First, people get better. So most people, something goes wrong, you may have to intervene in some way, but their body's doing most of the work. Someone once referred to my profession of internal medicine as just being a cheerleader for the neutrophil. Like, we don't really do anything. We just get things out so the body can heal. So you want to make as few changes as possible most of the time so the body can do what it's supposed to do to get better. Second, and the corollary of that is everything we do has risk of harm or has harm, right? Not even a risk, like it will hurt you a little bit. And the idea is you want the benefit to always exceed the harm up to some threshold where people get better, right? Get out of the hospital, get out of the clinic, their symptoms go away, whatever it is. So the more things you do, the more you stack harm. And because you don't have feedback of what's working and what's not, the more likely you are to keep stacking harm, iatrogenic harm, without benefit. So the faster you go at once, so the bigger your kind of intervention trials, the more you're likely to hurt people. And so in an intensive care unit setting, you do a lot right away because they're going to die the next day if you don't. And so it doesn't matter if you harm them because they're on their way to death. So you try a lot of things. But even in the ICU, we try and get feedback on everything we do quickly. If you're talking about like someone's blood pressure, you may have 10 or 15 or 20 years to work on this, right? And things people don't realize. So if you start like lisinopril, an ACE inhibitor for blood pressure, you get full effect of that medicine at about 13 months. So we're trying to change doses every few weeks, but the body will keep adjusting the medicine for over a year. And you're just basically ignoring all of that process. And so you want to iterate. You don't necessarily want to go slowly. You just want to make finite changes that you know work. And then you want to go over and over and over again to let the body heal itself. And so that mentality scales up to how you change your operations and then how you change technology. But it all fundamentally stems from that clinical model.
And so iteration also comes with, or this balances standardization, because the more that you iterate, the more that you deviate from the standards in some way or another, especially from the clinical research. So I see that you disagree, but maybe the question there, and then you can maybe explain to the audience why you disagree, is how did you balance that need for standardization? Because care teams need to know what they need to do for a patient of 60 years old with high blood pressure, but also with the flexibility to say, look, it might be different in this state, or it might be different for this care population. So also go out there and do whatever you think is best for the patient.
All right, I'm going to try two analogies, which are close but not quite. I've never perfected this. The first one, I want you to imagine a tool bench. So you have the bench space, and then you have all your tools beautifully mounted on the wall. If you think of clinical medicine, where the patient is the thing on the bench, like, sorry, but the patient is the project you're working on, every tool you grab off the wall should be standard in the same place. So if you need a hammer, you get a hammer, you don't get a shoe, right? You don't improvise a hammer, even though when you pull for the hammer may change in every patient, or every situation. So the idea would be the tools or the approaches are standard, even if the sequence is not. So if we're going to titrate blood pressure, we roughly do it the same way in everyone, but when we do it and the exact parameters of how fast can be customized. So that's what I mean. You can have so we let go of the word standard and went with systematic. If you take a systematic approach, it can look different every time, but there's discipline, there are hypotheses, and there's cause and effect built in. So your blood pressure is here, you're on this much medicine, I'm trying to get you to here, I'm going to change your dose at this frequency and measure these labs. Now, the plan for Andrew may be different than the plan for Rick, but the form of the plan is the same. And so you can measure that, you can monitor that, you can make sure people are adhering to discipline. The second analogy, similarly, is if you've ever been to like a theme park, so every ride is, again, standard, right? Like the roller coaster is the roller coaster, the log flume is the log flume. You can go to log flume 50 times, right? You could go around the park, you could stay in one area. And so you can't predict the path through the park, but each element can become systematic and standardized and measured on its own. And then what you're measuring about the sequence or the path is basically the more global population outcomes, right? There's plenty of art in medicine, no doubt about it, just like there's art in craftsmanship and there's art in theme parks. But there's much you can do to make people roughly behave the same way at certain intervals and instances.
And so from a product lens, how have you incorporated that flexibility then into the product? Because I was, for example, working with a large ACO the other week, and the way that they handle that flexibility is just like raw note taking. Like I'm gonna do this, then I'm gonna do that, then I'm gonna do that.
Mm-hmm.
But it makes it impossible to track performance, but also to track adherence. And so how have you enabled that flexibility in the tool, but also not too much flexibility, so you as a product leader and you as a clinical leader can still track what's working and what's not working?
Yeah, so we always had plenty of flexibility in the tool, for better or worse. And what we did was focus on outcomes first. And then I will say attempted, I'm not going to say we conclusively got there, backed from outcomes to like some version of best practices or guidance, so we could focus on adherence and activity measures. We started at some point looking at activities, and we realized that like there were too many, there's too many variations, and there's too much, all the attempts to standardize basically referred to like politics and rhetoric. So there's no data-based way to pick the right approach. It was like, who argued the best, right? Or who's the most powerful? And like, that's no good, so don't bother. And so we're like, all right, let's look at everyone's outcomes. Let's make sure we're aiming for the same thing. Then the next thing we would standardize are tools. And so honestly, we used a couple of sneaky approaches in the software side of the product. The first one was we had these things called issue names, since we're a problem-oriented record. And many of them were diagnoses, but it was a free text field. And so people would put things in like physician notes or like template, right? So people would hack our system to create features we didn't have. And so we used to look, see what things people were going through the trouble of building themselves, talk to them, and then build it. And so in the beginning of Chirp, we had to get features and functionality up. For a while, I was trying to change behavior by changing the software. I gave up on that. And I worked on changing behavior through leadership and management. And what Chirp and our technology became, and our service development team became, was where is there friction in what people are trying to do? Can we just remove it and remove it and remove it and remove it? Like, people are smart, they're trying to get the right thing done. So if they're struggling, let's just make the things they're trying to do easier for now. And we'll worry about them doing the right thing later, because they seem to already be trying to do the right thing now. So it's not really a problem that we have. The other tactic we used to use similarly was our task system was pretty open-ended. It was a way of tracking work. So we would just watch people's tasks and they're being created over and over again. And we would build features that would take over tasks. And then the last thing we would do, same thing, are post-it notes. So there's tons of post-it notes around our practices or like papers on the wall. Those two were clues as to what needed to be built in software. And so we, as you know, the challenge became when you had two practices doing things differently that were both right. Like, what do you do? And that's why we actually started initiatives across the country. This is pretty late. This was like 18, 19, we really got this going, where we had cross-practice collaborative initiatives on prioritized processes based on the outcomes they were set to achieve. And so much of the service building and kind of frontline product work was done by care teams across the country, supported by our product engineering and design teams, both service and technology. And then the training was supported by our training infrastructure team, but delivered by our care team members. And so it was like a for us, by us design model. And what that meant was the burden of change management and sales plummeted considerably. It's like we always got way cooler and better information doing it that way, but also we got more adoption faster. And that project and that kind of mentality and discipline that we built up over a year, 18 months is part of why when COVID hit, we went from a very physical practice model to an almost completely virtual tablets being delivered to people's homes model in about 5 weeks. Because the whole country of the company was already geared up to be working together to change operations. And so everyone knew who to talk to and what, like, it was all the patterns were already laid down. It's just the circumstances changed. And like that was amazing to see happen, how fast we were able to change everything because we were geared up and ready to go.
It's also a good example of why creating that culture of pace of change and continuous improvement, because you cannot predict a black swan event like COVID, but if you have the right culture, you can adapt and move quickly out of that. So I really like that example. You also mentioned when we were preparing for this call that in some ways Sherp was actually too open. Can you maybe elaborate a little bit more on what you mean by that?
Yeah, so you could name issues whatever you wanted. It wasn't until we started in Medicare that issues started getting linked to ICD-10 codes. You could write notes in kind of 4 or 5 different ways. Task fields were totally open text box. There wasn't any structure to them. Chirp didn't have an order to it. So I remember one of our designers, Matt Sisto, who really designed the hell out of Chirp over much of its life. He's like, Andrew, there are 5 different navigational elements. He's like, there's a left bar, there's a top bar, there's a second top bar, there's a right bar. Like, what is going on here? And so we had let it kind of grow out of control and had to redesign how you navigate a chirp. And so there wasn't a big sense of sequence. So a lot of how you used it was sort of in the world and in your care team. It wasn't inherent in the software. And so we started getting a little more opinionated about how you kept assessment and plans, how those were linked to diagnoses and tasks, et cetera.
So many of the people that read CareOps, they already are like bought into the idea of continuous improvement and continuous experimentation. The problem is that sometimes the leadership team is not bought into that concept, or you try to embrace that mindset into your organization, but it just like clinicians don't want it, product team don't want it, whatever. So what advice would you give to people that want to embrace that mindset of continuous improvement and like fuel that into their organization?
Yeah, so you absolutely must get the senior most leadership on board. So I was on the executive team. I was the youngest person on the executive team. I remember, so our technology team read the Phoenix Project back when I wasn't on it. I was just sort of like a design member. I read it. Then I got Duncan Reese to read it. And then Duncan, I remember he walked in one day and just slammed copies down on everyone's desk, the executive team. And I was like, read it. We're talking about it in 2 months. Like, and so that opened up a lot of eyes. We ended up teaching that. I taught that book tons of times across the country with all of our leadership team. I kind of never stopped giving up my changes and approaches to recruit each member of the team in their function, in their mentality, and kind of get them to see the light as I saw it. It was a hard thing to both be figuring this stuff out and have to evangelize it. Like I didn't have a ton of experience, credibility. I was kind of, 1 page ahead of them in the textbook. One of the most powerful things I did, I think, was I just took the chapter titles in the DevOps handbook and put it on a slide. And it's like the 3 ways. The first way, step 1, make work visible. And it just was a very nice step-by-step guide. And I remember a meeting where I was like, hey, so we want to be like at the bottom of the 3rd way, where we're learning an organization that rapidly changes things. Like Rashiki, you've been saying that forever. Right now, our work's not visible. Like no one can see what anybody else is doing. And then I spent 18 months inculcating just the idea of work visibility and how to make work visible in our practices, in our technology. Like that's what it was like. It was a lot of work and everyone wanted to win in the same way. But as you know, a lot of the stuff is counterintuitive. And so it takes people a chance to kind of get over it. But everything I learned, I also applied in my attempt to teach everybody else. So like we had a joke, we had a slide, it was a $750 slide based on the amount of time it took us to make it. And all it did, because it was show the annual calendar of work. Because the way we thought about it was like all this stuff happens, but then we talked about all our time talking about OKRs and improvement activities. But when you look at the whole year, like OKRs were like this much of the total work. Here's all the other stuff we already know we had to do that we were ignoring, that we don't talk about. We spent a lot of time on this. And there's this oh shit moment of like, do we have time to improve anything? Like exactly. Right. So like let's, or do we have time to do anything new? I don't know. Let's go figure out what we're doing first. So it took a lot of the executive team and we would like get buy-in, we'd wrestle it together. That team is one of the finest team people I've ever worked with. very smart group of people, very dedicated, very open to new ideas, willing to try things, but also very much push back, look for evidence, look for rigor. And so I don't know how you do it. The way you do it without the senior most team is you kind of have to do it within an organization to like find a winning area. And then when they're like, hey, how did you win so much more? You're like, oh, this is how. And then you see if you can pique their interest that way. That's sort of the other way to do it. It's tricky because it's, failure has success has 1,000 fathers, right? So everyone will claim they were responsible for that thing, not really the methods you're employing. So it's tricky.
Yeah, so in that last part, so obviously part of what I sell from a clinical lens when I'm talking about AWell to health systems and other companies is also that continuous improvement life cycle. And so one of the things that I've seen working is indeed you have one department that implements continuous improvement using software. And then it's like other departments coming to look because they're jealous and they have like an ego because they don't want to like lag behind. And then you can also get to that culture. But obviously it's much easier if you have that leadership in place. And I also would definitely recommend everyone reading the Phoenix Project. It's one of the most influential books in how we defined CareOps in many ways as well. Now, besides the books, you also mentioned the people. Part of that is also just good hiring practices. I think in the business case, there was something mentioned about the hug factor, and then some other things like what are like maybe 3-4 principles that you applied when hiring people, both from a clinical perspective, but also from a product and eng perspective.
Yeah. So hire for attitude, train for skill. Both were great, but attitude is more important. Rashika, our CEO, and Xander Packard, our COO, and then later president, spent a lot of time getting the first 100 hires right. They weren't all right, but they were personally involved in the first 100. Xander was involved for a very, very long time in interviewing folks. We had pretty elaborate people management, feedback systems, observation. We just did a lot to make sure that our people were there for the right reasons, wanted to be there for the mission, willing to accept the ambiguity of the organization. And then we also had a very open culture. So one of the best parts of these types of organizations is that no one has claim on smartest person in the room, right? You have like talented salespeople sitting in the room with technologists, with data people, product designers, world-class physicians. Like no one even understands each other's domains, let alone like can try and be the smartest person in the room. So there's two ways that goes, right? Everyone retreats to their corners, which is the typical approach. Or when you have leaders like Rashika and Xander, people start to see eye to eye and understand the benefit and wisdom of the different approaches and different disciplines. And so everyone gets a lot smarter and more capable as a result. So we got very lucky. We had a very good message that we broadcast to the world, which is we are going to restore humanity to healthcare. If that's what you want to do, come join us. If not, good knowing you. We had rigorous hiring and management processes. And we just got lucky. And we also knew how to keep people, as well as it was a nice place to work, right? Like just there's a million stories, but like I got a call from my wife. She was visiting a friend in Boston. We lived in Cambridge at the time. She parked in the wrong spot. Her car got towed. This is like early in the morning. So she like needed my help to go get her, but she had the car. So I walked in. I was like, hey, I gotta go get a zip car. This is in the zip car era, not the Uber era. I have to go get a zip car to get my wife so I can take her to the junkyard so we can get the car back, or the tow lot to get her car back. And Rashika and Xander both looked at me kind of confused, and then each slid their car keys across the table. Right? Like I was 26, right? Like that's the kind of place that gets people that want to stay there, that want to do hard work, that want to take care of each other. And so that level of like we take care of people is all the way through the organization. And so that helped a lot with both, again, who we attracted and who we retained.
I love that story. That tells a lot about the culture indeed. Another part of DevOps is continuous improvement. And in order to continuously improve, you also need to monitor what's working and what's not working. In terms of like getting insights on the metrics, when did that become a big focus point in your organization? Because I talk to many organizations that are very early stage and they don't even have like the dashboard set up, and they're like, I don't have the time to that. Like, what advice would you give on that, and how to get started and improve from there?
Yeah, there's a whole Schutzblog series on measurement, which I recommend you read because I remember it was like Thanksgiving of 2014, or it was like way too late in the organization when I challenged my 3 product owners to measure something by Christmas in the software. Like that was the level of complexity we had. We had clinical measures, obviously, but we weren't measuring processes or weren't measuring how people were using the software as an example. So I would say when we hit Medicare and we started to get a lot more rigorous about our measurement, we had people who joined the organization who were from bigger, more mature organizations who just expected these things to exist. And so they started to exist. And so that's why as you grow, you want to bring in more adults, right? Because the crazy founder inmates don't know what they don't know, and et cetera. So we always try to measure things. As you know, clinical work is inherently measurement based. You like pick a target and see if you can get to it all the time. But measurement's hard. It's a lot of work and a lot of it's observational. So my rough advice is in clinical services, intelligent observation is the most important kind of early measurement. I think most organizations go to quantitative measurement too quickly. When if you put a seasoned, experienced person in an environment, they can qualitatively pretty much tell you what's going on pretty quickly. And so even if you, so I always think of quantitative measurement as the smoke and qualitative measurement as the fire. So like, oh, their retention rate's going down, or their docs are quitting, or like their visit times are getting longer. That's a problem, but it's also evidence of some other problem. And you got to go and you got to look, the Gemba mentality. You have to go see what's going on. And so, you could measure all sorts of interesting things, or you could just go to a morning huddle and you could quickly see in a practice. You could do it virtually. Was everyone sitting around the table, were their faces in their laptops, or were they looking up and talking to each other? And if their faces were in their laptops, you had a leadership problem and a cultural problem in the practice every time. They weren't studious, they were avoiding each other, right? And so as soon as you pick that up, you knew you had to go work on leadership and see what they were doing. Usually they were undermining. There's like all sorts of complicated things they could do, and you had to fix the managerial problem, and then people start looking for their laptops. So my sense is there's a desire to want to get to quantitative and distant measurement. Early on, you want qualitative and very present measurements. You still want to be intentional and disciplined, but don't try and reduce things to numbers before you know how.
I like that. I think Jeff Bezos had, like, in an interview, said when the metrics say something different than the interviews, there is something wrong with the metrics.
Right.
So that's definitely a good lens to take from like an improvement, or like, how did you, sorry, I was losing my chain of thought, but how did you continuously monitor then the outcomes that you landed on to ensure that the improvements were also sustained over time and across different locations? Because what you notice in one location for one business unit, you could probably apply that knowledge to, like, hey, we've learned this in New York, let's also apply that into, for example, Florida or whatever. So how have you led to that continuous improvement cycles across different locations in the care model?
Yeah, so this one started with goal setting. And so the chain would go something like annual goal, which every annual goal comes down to revenues and costs one way or another. In our business, in all risk-based clinical businesses, revenues and costs are confusing. So you can't have revenue and cost goals by themselves because it doesn't get you anywhere. So we go a level of abstraction below that. We came up with these 7 drivers for the business. Then we would try and get a measure of current performance for the drivers, both for the company and then across locations. And universally, when dealing with a multi-site service business, I never found a normally distributed measure. So like a great example, we were having a challenge with clinician retention, or at least clinician burnout. Value-based care, primary care is very hard. It's much harder than fee-for-service because you never get to breathe. Like, it's always hard. People getting burned out. And so one of the complaints was like, we're running our notes at night. All doctors do this. It's horrible. Like, okay, cool. So let's measure work after work. And so we just put a measure in Chirp. We like set a definition of business hours, and then we just put a measure of every 6 seconds. It would check if you were using it after hours. Not a perfect measure. We also had other software like Box that it couldn't see when you were on the phone, good enough, right? And naturally we noticed, and our goal was less than 5 hours a week of work after work because someone was on call. And like, we didn't want to go right to zero because that's a big change. And if you looked at every provider, every physician across the country, there's like a sort of flat, and then like 6 people were screwing it up. Like they were like working like 10, 12, 20 hours a week. Everyone else like 1, 2, 3, 4, 5, whatever. And so then you just go see those 10 people, right? And you fix what's going on there. And so the key would be let your goals and what you want to see happen drive your focus and your prioritization. Then when you get your early measurements, look for the variability and focused on the highly variable ones, either positive or negative variance. But the nice part about our systems were that measurement stayed forever. So once we built the measurement in, it became part of the product that we maintained. So we always were watching work after work, even if it wasn't an active project, because if someone flared up, we would just call their manager and be like, just so you know, or managers can see themselves. They could see all their care teams work after work. So people could self-manage based on the data we generated iteratively over time. And so like, could we monitor everything? No. Were we always working on improving everything? No, because then we had nothing done. But managers were empowered and leaders were empowered to see what was going on in their domain, just to see who was getting out of whack that needed attention.
And from a data visualization perspective, like benchmarking, there's a lot of like clinical research that proves that if you benchmark providers between each other, they perform better because they want to do better than their peers. So what did people has access to? Was when I was a clinician, for example, working at Iora, could I see the outcome measures of a clinician working in New York, and what was the philosophy behind that?
Yes, so our information standard, and this was both clinical and performance, was across the organization. It's what I called need to not know standard. So if you've heard need to know, right, it's like you don't need to know unless you need to know, so everything's pretty much kept secret. That's no good. And then there's like full transparency, which is everyone knows everything. That's no good either, right? Like if we're gonna be doing layoffs, not everyone needs to know about that in advance, right? You have to control that information. It's important. And so same thing with patients. So the mental model was by default, everything was freely visible and available unless someone decided it shouldn't be for a good reason. And there's mechanisms to hide information. And so it meant like most of the time, most things were available, and some of the time, some things were hidden. And that's just the way things were there. And so if you had trouble with that, too bad, right? Like sunlight's a great disinfectant. So you're performing well. You don't feel shame. Raise your hand. Get some help. Talk to your peers. Right? Humility was one of our virtues, and so we wanted to encourage that with our folks. Different organizations with different cultures may have trouble with that level of openness, and I recommend no one go full transparency because it is important that information be explained and contextualized. So we were not a fully transparent organization. We were a mostly transparent organization. But that idea of like, would it hurt someone to know this? Let's hold it back for right now, which is pretty rare. It's a pretty rare occurrence.
And so one thing that you mentioned in the previous question was also like the prioritization. Obviously, you as a product leader, when you decide to build homegrown tools, there are like features missing all the time. And clinicians are very good at complaining, me included, when I was working in the hospital. Yes. Like we need this thing, and then we need that button there, and that needs to change. And so what was because I think you're a man of many frameworks. What was your framework when it comes to like prioritizing what to work on next from a product lens?
Yeah, so what I got to, I always hated roadmaps because I don't like, no one knows how long anything takes. No one knows if what you think it's going to do is work or not. And now you got to chain them up in sequence and say how long it's going to take. And it felt like a very elaborate exercise of lying to each other, which I'm not a fan of. So what we got to but you need some visibility into the future. So we did a couple of things. So first, Will Murnau, our head of engineering, used to write the fortnightly review. He's Irish, so he gets to use words like fortnightly with ease. And he would just tell you like what we're working on, what we're not working on, like what's now, what's next, and what's later or never. So people at least have visibility into like, here's the things we're not touching right now. So sorry if you're interested or not. So at least you knew you weren't like waiting forever in a queue that wasn't going anywhere. But our prioritization stemmed from company level performance and where we either wanted to linearly increase or catch up performance. And then it broke down to a series of bets like, okay, here's 50 ways we think we could improve this thing. Now go and try and make bets inside what to do, which was sourced amongst individuals. And so recently I put up a framework called Democratizing Prioritization, which is 4 questions that I created. Again, Duncan Reese is like, you need to tell every single person in this company, no, they can't have what they want. And I was like, that's a terrible job and I don't want to do it. What if I can get them to tell themselves no? And so I used these 4 questions and we distributed them to get people to realize that while the request wasn't wrong, why we weren't going to work on it now and even engage with them. Like if it's not hitting company goal and you haven't thought of any alternatives and you don't know how you're going to measure success, and it's just kind of an idea, do you really want us to work on it right now? Or here are the things we are working on, which you can come join and bring your creativity there. And so we would, corral and rally people towards existing ends instead of just kind of this forever popcorn. It took years to figure this out. It never fully went away, nor should it have. Like we didn't want no ideas, but it took a long time to get that balance right. I'm not sure we ever did, of listening and sensing from the crowd versus prioritizing so we can get things done. It was probably the least fun, most important part of my job as a product leader.
I see we only have 3 minutes left. So a final question on my end. What advice would you give to people that, for example, read the Phoenix project and think, heck yeah, or that know CareOps and think, heck yeah, I want to have this in my organization? Like any final advice that we didn't touch upon that you think is worth mentioning?
Yeah, step 1 is always make work visible. Step 2 is reduce work in progress. There's not really step 3. Like, but if you do those 2 things, which are hard, and you see the work everyone's doing and show it to themselves and show it to each other in as real time as possible, and then you start to realize how much you're doing at once, and you believe with your whole heart that the less you do it once, the more you'll get done over time. Every step beyond that is idiosyncratic and specific. Like that will lead you where you need to go for your organization, or those 2 beliefs that you've got to see the work, and that you have to reduce WIP. And the underpinning belief to all that is you cannot predict the future, so stop trying. There's a belief that people want to predict the future so they can get an advantage of sequence by shoving as much stuff through the pipe as possible. That's why they have high work in progress. Something goes wrong, everything fails. They're like, oh, I got it wrong that time, but next time I can predict the future. So you can't predict the future, so stop trying. And the less you do it once, the more you'll get done over time. Make your work visible, do those things, and you'll make tremendous progress quickly.
I love that. Any final things that you want to say to the audience, where they can find you, what they should read, how they can reach out?
Yeah, thank you for listening. I try and put all the stuff down on the Schutz blog whenever I can. I'll put it in the chat one more time. And there's questions we did not get to, I'm sorry. My goal of the Schutz blog is to be as helpful as possible. So there's resources in there. There's books that I recommend. There's links to a million other things, our own experiences. And then I do run an advisory company called Schutzworks. So if you lead a company and you're struggling with this stuff and you want to talk about it, let me know. It's like I have a whole new panel of patients in the form of companies that I get to work with. So thank you very much, Rick, for having me. And thank you, everybody, for joining.
Thank you, Andrew, for your time. And we chat soon.
Take care. Bye.